And now let's go with the next speaker, the last one. And now is the moment to go with Dr. Rigo. Dr. Rigo is going to speak us about the clinical cases and expected lack of in-brace correction. Dr. Rigo doesn't need any introduction, but I would like to remark all the work he has done during more than 40 years working with scoliosis patients, also other spinal disorders, and one of the most recognized research and person that is always making questions and trying to resolve them through the research and papers. It's an example for all of us, the energy this person has and is helping and pushing us to do more. Let's go with his presentation.
Hello again. This is a case presentation that I used a few months ago in a course organized in Valencia by Teresa Vaz, David Farrington and Oscar Riquelme. And it's about an unexpected lack of in-brace correction. The girl was 13 years of age when visited for the first time on April 22. She was premenarche, had a negative family history, and the diagnosis was idiopathic scoliosis with the major curvature reaching 31 degrees. So she was recommended for full-time bracing, and she started bracing on June 22. The first in-brace correction on July 22 was showing a no correction. So you have to decide here, when correction is 0, you have to decide what to do. Your question is, the scoliosis not allowing to be corrected, or is the brace quality not good enough? And you have to decide, if the good quality is not good enough, what to do, whether to put more pressure, try to correct more by pushing more, or to change the brace. I saw the girl for the first time in October 2022, and I discovered, and they report me, that the doctor who saw her recommend just to push more by adding pads inside. And I had a look at the brace, and my conclusion was that the brace was had a poor standard in some of the main principles of this technique. So I decided at that moment to order a new x-ray to see the situation at that moment. And in November 22, she had shown a progression to 40 degrees. So you could define this as a failure of bracing, due in this case, to my opinion, to the quality of the brace, not to the quality of the scoliosis, because you can see in the original x-ray that the rotation component is not a big one. There is no big vertebral deformity, so you could expect a good in-brace correction. So this was my decision to make a new brace. And when you look at the new brace that I made for the girl on the right side, and you compare it with the previous brace, you see that the level of the contacts is not really different. The design in the dorsal view is not really very different, apart of the design of the pelvis, but the pelvis is not going to be the reason for getting a better in-brace correction. And the x-ray in brace with this second brace was showing in-brace correction of almost 50%. So this is confirming that the lack of correction was due in this case to the poor quality of the brace, not to the poor quality of the scoliosis. Again, the two braces and the two x-rays together, so you can see that the brace from the back is not so different. And to understand what happened here, let me explain in few words the principle of correction of all the Chanute type braces and derivatives. Chenu himself was inspired in the casting technique. In fact, she wanted to replicate the principles of casting, but on a neutral or death mold. I mean, he wanted exactly to prevent to do the procedure with the patient in vivo. So he established the principles to do this correction on a positive mold. And the principles are the same, like in casting: elongation, 3-point system guiding the frontal plane alignment, a couple of forces for the rotation with counter rotation forces. So all these are well-known principles. But there was another one important for me in this case, is the action that the practitioner doing casting was doing on the thorax in order to reshape or modeling the rib cage and control the lordotization of the thoracic spine. The idea is apply a force on the ventrolateral prominence in order to reduce the major oblique diameter of the thorax with a stopping point dorsally and laterally on the convex side, and increasing the sagittal diameter of the thorax in a way that the brace is able to produce breathing mechanics that is pushing out the spine from the thorax, so allowing for intervertebral detorsion, the main way to prevent about the lordotization and the bad compensations. So I have been revisiting the principles of this brace during the last years, like I said this morning, and you can see here enunciated the current principles, pre-elongation and 3D alignment. This is something we do on the mold before designing where the brace is going to contact the body of the patient. Then we provide the contact areas in order to produce these forces or these principles, regional derotation or derotations, depending on the curve pattern according to the classification, caudal and cranial counter-rotational forces, a 3-point system guiding frontal plane alignment, proper sagittal plane profile and balance, and finally, this is very important, proper shape and orientation of the contact areas, providing this dynamic mechanism to fight against the lordotization. So when you look at the two braces from the front, not from the back, then you can realize about the important difference. The previous brace had no control on the anterior lateral rib arm and had no practically lateral support to guide the frontal plane correction. So the forces applied by the dorsal pad were, let's say, lost because there were no counter forces. This is a way exactly to lose correction, and this is the main difference. The current brace has a good control of all this area, is this ventrolateral area, and also the lateral support to guide the frontal plane alignment. And you can see here the two braces from the top. You can see that the previous brace had no change in the major oblique diameter, and that sagittal diameter was very small, and in the second brace the major oblique diameter was really reduced with an increase of the sagittal diameter. So all of these differences were enough to produce this so relevant difference of in-brace correction. It's not always about these principles. This is, for example, a brace that I made for a girl with a right thoracic scoliosis that I expected also from my clinical experience a good in-brace correction. When I made the first brace following all these principles, I failed. I mean, the in-brace correction was totally insufficient, very poor. And I realized that the principle failing here was the first one, the pre-elongation and pre-alignment of the mold. I designed the contacts having the mold not previously elongated enough. So I remade the brace, with a mouth more elongated and better aligned. And then I got a good in-brace correction, 50% again in this case, although this is not possible in all the scoliosis, of course. You can see that this was possible without a relevant compensatory proximal curvature. You see that the left trapezium line is higher than in the first brace, but this is not associated to a proximal curvature, because the problem of the proximal curvature is when you have an imbalance between the forces forming the three-point system, producing a bending effect and bringing the correction that you get in the main thoracic region up to the proximal region. So this is clearly not producing the torsion, producing compensation, and the shoulder here is going up due to this bending moment. Let's say the objective, the main objective, would be to get the best possible correction, but still with a good balance at the transitions of the main thoracic curvature down and up, and also at T1. This is at least the ideal thing, what we are looking for. So as a final message, some brace concepts are really complex. When the in-brace correction is not the expected one, interpreting why is that is not easy. It is better to make, generally speaking, I used to recommend to make the brace a new brace. I think it's better than adding pads in size to push more, because then you in some way break the balance of the brace. And more complexity has a concept higher risk for iatrogenic effects, so take care with this. And it is not about names, but about education, specific knowledge and experience, clinical experience, in a well-formed interdisciplinary team approach like the one you have here. The best brace, to my opinion, is not based on a name. The best brace is the one that the team knows the best and works better with it. Thank you very much.